Hi guys, this is chapter 17, Professor Elliott here. Chapter 17 is about substance abuse disorders. We've heard a lot about these in terms of medication that is prescribed. So you know a lot of these side effects. We did touch on treatment, toxicity, and overdose. So this is kind of a targeted look at the abuse of substances, which take a second here, and I want you to write down what is tolerance and what is dependence and how does it really affect a patient. So pause this and let's discuss here. All right, you ready? So tolerance is when a medication does not work as well because a patient has used it. So it's this repeated use of drug over time that can actually result in receptor changes. So the drug is not going to work as well. You need more to produce that effect. And then dependence, when we talk about it in terms of physical dependence, is when we need that drug or else we'll have our withdrawal symptoms. So it's typically in response to this long-term use. And, you know, when we talk about addiction, which we've now renamed substance abuse disorder, we have addiction, and I know we discussed how patients really shouldn't have that fear of addiction with cancer pain or chronic pain because if the pain's being treated appropriately, which is absolutely true, but these patients do develop tolerance and dependence, which we need to be aware of, but we don't want to treat their addiction, right? We don't want to make that better. A patient has cancer, we don't need to take those drugs away because we're concerned. We're more concerned about providing care that is comfortable. So please kind of have a good idea of that for the next exam. So opioids themselves include prescription drugs such as Percocet, oxycodone, includes heroin, opium, and it includes fentanyl. Fentanyl is much more coveted on the street now than heroin is because it is stronger. Opioids, people like them because they cause euphoria and relaxation. Withdrawal looks awful, but it cannot kill you. So when people say they're dying from opioid withdrawal, they're not. They're really miserable, but they're not dying. The symptoms include nausea, dysphoria, they get lacrimation, which is a lot of tearing, they get a runny nose. I really don't understand the physiology there, but that does occur with opioids. They get pupil dilation. They will tell me that it's like the absolute worst flu they've ever had times 1,000. They look really sick. They look awful. You know, some people go through withdrawal because they want to quit. Other people are going through withdrawal because they can't find any heroin. They don't have any money. So, you know, and it doesn't really matter. We're there to help them. Clonidine is a blood pressure medication. It's an alpha-2 agonist, which results in that decreased sympathetic nervous system. Clonidine can actually be used in ADHD, but it is really helpful in opioid withdrawal. It's not going to treat it. It's not going to replace the opioid, but it does help with the symptoms. It is a blood pressure medication, though, so you want to check your patient's blood pressure so you don't bottom them out. In terms of toxicity and overdose, what's the most life-threatening? Respiratory depression, and what do we treat it with? Naloxone. Very good. Treatment of addiction, we talked about all of these things, but I want to reiterate. If we look at the far right, that's naltrexone. Naltrexone is different than naloxone. Naloxone is Narcan. Naltrexone is Vivitrol. It is a once-monthly injection. Think of it like a long-acting Narcan. It's an antagonist. Concern with this, though, patient, say they break their leg, can't give them opioids, right? Because they have this long-term blocker. Patient must be free from opioids 1 week prior to dose. Give the injection every 30 days. The injection is kind of painful. Check the injection site for any infection or irritation. We can also use this in alcohol addiction. Not for alcohol withdrawal, but for treatment of addiction. Methadone we talked about. Methadone is a full agonist, which means that it is going to create an effect just like the heroin did. Methadone is very long acting though, half-life of 24 hours, and it does not produce euphoria. A lot of people kind of argue that methadone is a substitute for heroin. My argument is anything that helps them get off of heroin is good for them. Methadone is dosed daily. Buprenorphine, as you can see up here, so we have buprenorphine, which is Subutex, and buprenorphine naloxone, which is Suboxone. Buprenorphine is a partial agonist, so it has some action at the site, but some blockade. Suboxone has that addition of naloxone. If the patient abuses the Suboxone, the naloxone will be activated. Otherwise, it is inactivated. So if it's abused, the naloxone is activated and it's going to completely block the receptor. Our next class is stimulants. So you can think of these effects very similar to the side effects of Adderall and Ritalin or methylphenidate. These medications result in elevation in mood, reduction in fatigue, increased alertness. All of these up here are stimulants. We see an increase in norepinephrine. Withdrawal or detox is going to be the opposite, right? These patients are up, they have increased heart rate, they have, insomnia. So these patients are going to kind of go into like a depression hibernation. They're going to have this psychomotor retardation, so they're not going to move very much. That's what that means. Hypersomnia, they're going to eat a bunch, they're going to sleep a bunch, they're going to be depressed. Toxicity and overdose, we do not have a reversal agent. We do not have, there's no Narcan for these stimulants, so the treatment is supportive. Patient can have seizures, coma, or cerebral hemorrhage, which is bleeding in the brain. There is no treatment of addiction. Next is depressants, and this is kind of a big class. These overall are going to kind of bring you down. CNS depressants relieve anxiety, irritability, and tension. Withdrawal, kind of get the opposite. So we're up, delirium, seizures, increased BP. You're going to see all of that a lot more with your benzodiazepines. If you remember, our reversal agent for benzodiazepines is flumazenil. Benzodiazepine withdrawal can kill you. Benzodiazepine and alcohol withdrawal can kill you. Okay, opioid withdrawal cannot. Benzodiazepine and alcohol withdrawal can kill you. Your body is so used to being sedated with that dependence that it's built up with benzodiazepines and alcohol that it is unable to go without it. It gets this hyperstimulation that can result into seizures and death. We have a lot of concern with barbiturates as they're also very sedating, which is why they've kind of been pulled off the market. But I think you may be able to find them. I don't know. No patients come in the ER and say, oh, I'm using phenobarbital. But we use this to treat addiction. Well, we don't use it to treat addiction. I'm sorry. To treat addiction, we want to taper these medications. Next is alcohol. Alcohol to me is the most concerning. This is typically a very long-term addiction. It can be hidden, and alcohol is a legal substance to buy. Alcohol causes CNS depression. We know a lot of alcoholism or alcohol substance abuse disorder is related to genetics. Withdrawal, again, can be life-threatening. The symptoms we get are elevated everything, right? The body's so used to being sedated. When we take that away, we have this hyper arousal. All the vital signs go up. Patients are jumpy. They start to hallucinate. They can have seizures. They have agitation. We treat alcohol withdrawal with benzodiazepines because that is something that we can sedate a little bit with until the patient gets off the alcohol out of their body and kind of comes through withdrawal. Toxicity and overdose. Alcohol overdose can result in respiratory depression. Aspiration is when a patient vomits. The contents go into their mouth. It mixes with bacteria and it goes back down into their lung. It causes a very, very bad pneumonia. Treatment of alcohol toxicity is supportive. We do not pump people's stomachs. It's recommended against. Treatment of addiction. This is not treatment of withdrawal. This is treatment of addiction. Disulfiram and naltrexone. We talked about naltrexone. Disulfiram or Antabuse is a medication that we give. The patient takes it daily. If they drink alcohol, they get very sick. They get flushing, they get low blood pressure, and they throw up very violently. Now, this does not just pertain to drinking alcohol. This also pertains to mouthwash with alcohol in it, any food with alcohol in it, like a chicken cooked in wine. They cannot put lotions on with alcohol. They can't be around paint. So it's really, really wide, and you really need to understand all of the things that the patient can't be around. I wanted to touch a little bit here because you may give a banana bag to your patient or a B vitamin replacement. And I want to tell you why. So patients with chronic alcohol use do not have enough B vitamins, specifically thiamine or B1. With this deficiency, the patient is no longer able to convert glucose into energy for their brain. The lack of B vitamins stops that. Their brain essentially starves. It leads to chronic brain damage, irreversible. We have Wernicke-Korsakoff syndrome. Wernicke, and this is what it's called, B vitamin deficiency in these patients is called Wernicke-Korsakoff syndrome once it's created brain damage. The symptoms we get are some confusion, some staggering gait, and some oculomotor or eye dysfunction. This is a medical emergency, and we need to give parenteral or IV thiamine, which is B1. The other part to this is Korsakoff syndrome. Korsakoff syndrome has a significant overlap with Wernicke's and stuff. So Korsakoff-Wernicke syndrome. Korsakoff psychosis is more of a memory impairment that you're going to see. This is an example of a brain. This is a normal brain to the left. This is a brain with chronic alcoholism on the right. The brain has shrunk. So we see all of these sulci, or the actual brain tissue, in the middle here. Those little kind of circly areas that are dark are the ventricles. This brain we can see has shrunk a lot due to the chronic lack of B vitamins. Next, we have nicotine. Nicotine has a perceived calming effect. Patients smoke cigarettes, chew tobacco. When the withdrawal of nicotine occurs, once a patient has developed a physical dependence, patients will get irritability and cravings. Toxicity really only occurs maybe in children when they get a hold of something with a high amount of nicotine in it. Treatment supportive. Treatment of addiction, our first line is stuff that's available over the counter. This includes nicotine patches, gum, lozenges, spray. Patients in the hospital can get a little nicotine inhaler. In terms of prescriptions, we can give bupropion. Remember, that's Wellbutrin. I talked about how that's marketed as Zyban. It's an atypical antidepressant. It helps reduce cravings. And then our other one is varenicline or Chantix. It actually comes in kind of a dose pack, so you dose, a little bit more. And it is an agonist to nicotine receptors. The varenicline can cause drowsiness. I've also seen it cause kind of a hyper-alertness. It can also cause suicidal ideation and crazy dreams, so definitely tell your patients to notify you if they're having any suicidal ideations.